Hi, I'm Claire, and you will probably be able to tell I'm originally from Belfast. I normally live in London, but I am actually in Belfast at the moment for the next 5 weeks. So I'm coming from the sunny countryside just outside Belfast at the moment. Basically, as Kirsty said, I was diagnosed with endometriosis in 2016. This is a part-time but reasonably full-on involvement for me with Endometriosis UK. I basically got involved with them after an information day they did at my hospital just after I'd had surgery in 2017, and so I have been kind of on board and working with them since then. We normally run Facebook groups we normally run in-person support sessions at 3 sites across London, but at the moment obviously we're doing it online. So but I'm very happy to come and speak to people about it. I'm a bit of a zealot about endometriosis. I go around talking to everybody about it, whether they want to hear it or not, especially men. I've frightened quite a number of male acquaintances of mine with my talk on endometriosis. So I'm going to share my screen hopefully here, and so I can show you the little presentation that I have at the moment. I know we'd had understanding endometriosis as the topic, but understanding endometriosis is in itself a really difficult thing because there's so much about endometriosis that we don't know yet, which is one of the problems. For a long number of years, endometriosis was really quite badly funded and very under-researched, like a lot of other conditions that mainly affect women and those assigned female at birth. So we're on a bit of a catch-up process at the moment with endometriosis. So what I've titled it instead is What You Need to Know. This is kind of basic, quite basic level stuff. So if anybody has more, questions where they know a bit more about it and they want to ask something a bit more in depth at the end, then obviously I can absolutely do that. Just a little warning, obviously we're going to be talking about symptoms and stuff, and some people find that quite upsetting. I want you to know that every support group that I've ever had, we've had people who have we've had to get the tissues out. It's a very emotional topic, and particularly for people who suffer with it, it can be the first time that they've ever talked about it publicly. So please take care of your mental health and don't feel bad at all if you feel at all upset during this, because it's not going to be anything graphic at all, but it is just something that people can struggle with talking about. So first of all, what is endometriosis? Well, endometriosis is the name given to a condition where cells similar to the ones in the lining of the womb are found elsewhere in the body. You'll find a lot of people who will tell you that it's where the lining of the womb grows outside of the womb, but it's actually not. They're not exactly like the cells that line the womb, but they're of a similar kind. It can grow anywhere. Usually within the abdominal cavity, so it can grow on the outside of the womb, it can grow on the ovaries, fallopian tubes, bladder, bowels, the inside of the cavity, so it can grow on the peritoneum, which is what they call the inside of the abdominal cavity. It can grow in rare cases on the diaphragm, and actually some people have thoracic endometriosis where it's in their chest. Some endometriosis cells have been found as far away as the eye and the brain, which is pretty uncommon. And some cells have been found in people who are assigned male at birth. Now that's very rare, but it does make us think very carefully about what the cause of it is, which we're still not sure about, as we'll discover shortly. So each month these cells react in the same way as those in the womb, building up and then breaking down and bleeding. But unlike the cells in the womb, obviously, that leave the body as a period, this blood has nowhere to escape. So this causes inflammation, it causes pain, it can cause adhesions, and that's obviously a huge problem for anybody who's having a menstrual cycle every month. In the UK, around 1.5 million women and those assigned female at birth, which can apply to non-binary people or to trans men. There are quite a number of trans men who've been quite open about the fact that they have it, are currently living with the condition regardless of race or ethnicity. Endometriosis can affect you from puberty to menopause, although the impact may be felt for life. Now this, some people think that it goes away immediately when you have the menopause, because obviously your hormone levels drop, but some people have adhesions or scar tissue on organs, so it can continue to cause pain for people who have scar tissue after menopause is over, depending on what the internal damage from that is. Endometriosis in the menstrual cycle. Here we are. Here's the little diagram of what everything is. And you can see quite clearly there, patches of endometriosis on different parts of it. Now, I have to tell you, I've seen some actual photographs of endometriosis, and I can tell you it's nothing like as easy to diagnose as that. There are about 5 or 6 different presentations of endometriosis. They're all different colors. Some of them are incredibly tiny, which it leads to one of the problems that we have with treatment and diagnosis, which is that unless people are very skilled at spotting it, it can be incredibly hard to spot. I wish it was as clear as it is on this diagram. So every month, obviously, the body goes through the normal hormonal changes. Hormones are naturally released, which cause the lining of the womb to increase in preparation for a fertilized egg. If pregnancy does not occur, this lining will break down and bleed, which is released from the body as a period. But in endometriosis, the cells grow in other parts of the body. They also react to the menstrual cycle in terms of estrogen and progesterone, and so obviously they can't escape. And so this can cause, as I say, inflammation, pain, and the formation of scar tissue. It can also cause organs to stick together. So there'll be quite a lot of people who will have severe endometriosis who will have an ovary that is stuck either to the uterus itself or to the abdominal wall. It can also stick the back of the cervix or of the vagina or of the uterus to the bowel. And it can also have adhesions between the reproductive organs and the bladder, which is one of the reasons why it's so difficult to work out where it is, because it can affect so many different kind of areas within that cavity. So some facts and figures, which is always the bit that makes me slightly grumpy when I read it. 1 in 10 women and those assigned female at birth of reproductive age in the UK suffer from endometriosis. So that's a huge percentage. So, pretty much everybody knows somebody who has endometriosis. 10% of women and those assigned female at birth worldwide have endometriosis. That's 176 million people worldwide, which is a huge, vast amount. The prevalence of endometriosis in those with infertility may be as high as 30 to 50%. So obviously there's a lot of people who only discover that they have endometriosis if they're lucky enough to not have had any symptoms or not have had extreme symptoms. Some of them may discover that they have endometriosis when they come to try and fall pregnant and find that that's really difficult. That happened to my own family, to my mum. That's how she discovered she had it. Endometriosis is the second most common gynecological condition in the UK. The first is polycystic ovaries, which it just shows you how many women have that if endometriosis is the second most common gynecological condition. Fibroids, I think, are right up there as well. So it's and often people have 2 of those. I mean, fibroids and endometriosis are very commonly occurring. So a lot of people will have both. Endometriosis affects 1.5 million women in Britain, a similar number of women that are affected by diabetes. Now, obviously, diabetes is a kind of a cross-gender experience, but if you think about how much we hear about diabetes and how much we hear about funding for diabetes and research into it, it shows you how much, what a widespread problem it is. On average, it takes 8 years from onset of symptoms to get a diagnosis. Now, that's an average. So I was very lucky. I got diagnosed very quickly. Some people have had 20 years of symptoms before they get a diagnosis, which is pretty shocking and really, really shouldn't be the case, because it's ruining people's lives to do it. And as if to underline that, endometriosis costs the UK economy 8.2 billion a year in treatment, loss of work and healthcare costs. And that's before we even get to, the damage that it wreaks on people's lives in terms of their relationships, their friendships, their social lives, their mental health, everything about it. So it's a really big and very widespread problem that's often not been talked about. So what are the most common symptoms of endometriosis? I've spelled symptoms wrong. I thought I'd spell check this. There you go, symptoms. Endometriosis is a difficult illness because some people have no symptoms at all and don't know they have it until they go either for scans for something else, or they go with other symptoms, and sometimes it's found as an incidental finding. But the most common things that people have are chronic pain, which is mainly obviously pelvic pain. Fatigue and lack of energy, which is a huge one for a lot of people, and it's not one that people necessarily know about. Sometimes you think, why am I tired all the time? And it's believed to be down to the fact that because it's an inflammatory disease, it's there's a lot of inflammatory activity going on in your body. So like any other kind of inflammatory disorder, it saps a lot of energy and it takes a lot out of you. Depression and isolation is a big one. A lot of people who have very bad symptoms find that they get very depressed, both by their physical health and their symptoms, but also because it gets in the way of them wanting to go out and do their social activities, or wanting to work out of the home, and lots of things. I mean, that is something that takes a huge toll on people's mental health and on all aspects of their life. A huge one is problems with couples' sex life or relationships. That is something I'm not going to go into in huge detail today, but there is loads of stuff on that on the Endometriosis UK website. But it can cause painful sex. It can cause people to not want to have sex. It can cause strife in relationships, obviously, when one half of the couple is often feeling too unwell to both go out and also to engage in a normal relationship. An inability to conceive is obviously one that is a big factor for a lot of people. It doesn't affect everybody, but it does affect it affects up to about 50% of people with endometriosis will have problems with conception. And then obviously difficulty in fulfilling work and social commitments. One of the problems with endometriosis is that sometimes your symptoms can be a bit unpredictable, and therefore you say you're going to do stuff, and then you find that on the day you're having a really bad flare and you can't necessarily carry through, which is very difficult in terms of working around work and also making arrangements with people. However, the positive thing is there are treatments out there, and sometimes it's a question of trying a number of them, but there are ways of keeping it, trying to keep it manageable for people depending on what their level of symptomatic suffering is. Okay. What is endometriosis not? It's important to remember that. This is just a little caveat. Endometriosis is not an infection, so it's not anything that you can get rid of. It's not a sexually transmitted disease. It's not something that you can either pass on or that you can treat with antibiotics. So it's not contagious, as it says there. And the other thing that's very important to remember is that endometriosis is not cancer. It is a disease of unusual cells which do things that they're not supposed to do, but it's not cancer. It's not something that's going to spread in that kind of way. Sometimes you hear stuff about people's cancer risk, ovarian cancer and stuff being raised. It's very, very slightly raised, but it's, we're talking minute percentage points. It's really not a particularly statistical significant way. So we say that to people not so that they don't panic about it, particularly I think when people have large cysts or they're told about things, then obviously people can sometimes get anxious that it's something more serious. So obviously what we say is that people can have a very different amount of pain and discomfort from one person to the next. Some people have no symptoms at all. Some people I've worked with and spoken to are literally bedbound for periods of time. The thing to say that seems really counterintuitive to everybody is the amount of pain and discomfort and symptoms that you have are often not related to how widespread or severe your endometriosis is. I know people who have 1 or 2 tiny little spots of endometriosis who are in agony and have severe bleeding and all kinds of things. I personally have loads of endometriosis, absolutely everywhere. I mean, I've got bowel involvement with my endometriosis. I think I have some of it on ligaments in my back. Most of the time, I am more or less symptom free. So having severe endometriosis doesn't necessarily mean that you have severe symptoms. So that's one of the tricky things about getting diagnosed and finding out what your needs are, is that they do tend to treat on symptoms and on fertility, if that's something that's important to people, rather than on the degree of endometriosis that you have. It's also thought that they tend to stage endometriosis, which isn't particularly helpful, but they go from stage 1 to 4. And stage 1 and 2 is kind of mild endometriosis, which is located in individual spots. And then stage 3 and 4 is more severe and widespread. They're actually beginning to think from a genetic point of view that stage 1 and 2 may be a different illness from stage 3 and 4, which is why if you have stage 1 and 2, it doesn't necessarily proceed to stage 3 and 4. So if you have mild endometriosis, you might have mild endometriosis all your life and it may never develop to being more severe. So the classic endometriosis symptoms include painful periods, which everybody always talks about. One of the questions we often get asked, well, how painful is painful? I mean, I think one of the problems is that women are told that periods are painful and that you come to expect that. Periods should be, maybe slightly painful, but if it's the kind of pain that's keeping you out of work, keeping you dosed very heavily on painkillers, meaning that you can't go out and do things, or that you feel really ill, or some people have vomiting, all those kind of things. Those things are not normal, and we're trying to get it introduced. I think they've succeeded in some places, but not in others, and I can't remember which areas of the UK currently have it, but we're trying to get menstrual well-being put onto the curriculum, because it's not being taught to girls sufficiently early what they should expect. And I think a lot of them have heard horror stories from family and friends about, oh, they have the worst periods ever, and they've come to expect that that's normal, and it's not normal. And we want to get that through to girls very early on, so that if they do suffer very badly, they start looking for diagnosis or treatment much, much earlier, which we hope will kind of stop this very long period of being diagnosed. Pain during or after sex is a symptom. This is quite often due to adhesions and stuff on the inside, or things. One of the other things that can be a huge problem, which I'll talk about a little bit later, is women in particular are always being told about doing pelvic floor exercises. We're always being told to tighten our pelvic floors and keep tightening them. And this is something you get told from an early age. Otherwise, if you have children, you'll have problems. You'll be weighing yourself. But what actually happens with endometriosis and a lot of other gynae conditions is that your pelvic floor is actually too tight. It's overactive. And that can cause people problems with pain or with penetration at all, because they're all tight in that area. And there is something called pelvic physio, which I will talk about later, which is a revelation to a lot of people. So infertility, again, can obviously be a symptom. And as I say, many people don't find out that they have endometriosis till they go looking about infertility problems, to discover then that may be part of the cause. Painful bowel movements. This is for people who may have bowel involvement with the endometriosis, or may have endometriosis on nerves leading to the bowel, because you can actually get endometriosis on nerves in the bowel. So that is a symptom that should always be investigated. And fatigue, as I mentioned, which is a really big one. But here's some others that may cause, because actually you'll find that for every woman or person who has it, they will have a relatively different range of symptoms. So on a pain level, some people will have painful periods. Some people will instead of, or as well as, have pain on ovulation in the middle of the month. That's quite common, particularly for people who have endometriosis on their ovaries, or who have ovarian cysts, which can be caused by endometriosis. Pain during external examinations is a big one, and also for people having smear tests. If you've ever thought that you might be you think you're slightly wimpy about smear tests, it can often be the fact that actually there's stuff going on there that you didn't know was a problem. And again, tight pelvic floor can come into that. Pain during or after sex, and pelvic pain, which is not necessarily at any particular time of the month. When I was diagnosed, I had very large endometriosis cysts, and I was in pain all the time, and it came unexpectedly, and so it doesn't necessarily always have to be linked to your cycle. Bleeding symptoms, people don't talk so much about bleeding symptoms with endometriosis, but some people have very, very heavy periods, or they have bleeding for a long time, or they have spotting or bleeding between periods. And some people have loss of old or dark blood before periods. So that can be like a kind of a brown discharge. And that's something that an awful lot of people commonly have. As regards bowel and bladder, some people have painful bowel movements. Some people may have bleeding from the bowel. Now, it's really important with this and with the bleeding, with any vaginal bleeding, there are other things that can cause this, obviously, and most of them are harmless, but some of them can be more serious. So obviously, don't assume that any symptom that you have like this is endometriosis and ignore it, because those, always go and get it checked out. And often, if you go for diagnosis with bowel endometriosis, they will sometimes do colonoscopies and stuff as well, just to check that there isn't another cause behind it. Symptoms of irritable bowel. An awful lot of women who have endometriosis have been told that they have irritable bowel. Often they don't have irritable bowel. What they have instead is bowel endometriosis. So all the symptoms of irritable bowel can happen. Diarrhea, constipation, bloating, stomach cramps can all be part and parcel of bowel endometriosis. Pain when passing urine. Some people have it on their bladder, either inside their bladder or on the outside, which can cause them to have pain when passing urine. It can cause them also to have a bladder that doesn't empty properly, so they can get urinary tract infections, which can also cause problems. And then pain before or after passing urine or opening the bowel. And again, that can be down to nerves or down to where it is specifically. And then other symptoms, tiredness, lack of energy, we've talked about. Depression, again, can be one that comes on. Back pain is one that's back and leg pain are not talked about much, but the nerves in our pelvis are very close together, basically. And so the brain is not very good at interpreting where your pain is coming from. So sometimes people get pain in their lower back, or they get pain in their legs, which is all to do with the nerves. Sometimes people have endometriosis on the nerves, but also sometimes it's just general inflammation, which can cause people to have back and leg pain. So that's quite a common symptom that doesn't get talked about an awful lot. So what causes endometriosis? Well, the truth is we don't know. And this is partly because it's been quite underfunded. So there are a number of reasons. I'm only going to go into these very briefly because they're quite complicated. But there are lots of possible thoughts about what causes it, which are being researched. The first of which is called retrograde menstruation, which is where the supposition might be that some of the blood from a period is going back up the fallopian tubes and out into the pelvic cavity. Now, this has been there's been a little bit of rolling back on this, thinking maybe this isn't the cause recently, because it doesn't explain some of the ways in which people present with it. But they think that everybody probably has some menstrual blood that goes back up the tubes, but that it may usually get kind of wiped out by the immune system. But we don't really know about that. It's been kind of, that was thought of as a prime candidate for some years, but I think that's been kind of rolled back. Genetic predisposition is definitely one that has a factor. A number of us who have it have family histories of it. So my mother and my sister both have endometriosis. This is apparently, according to a geneticist we spoke to, more common in people who have severe endometriosis. So people who have stage 3 and 4 are more likely to have a family history of it. We're only really now starting to get to the bottom of that, because obviously in our grandparents' and great-grandparents' generation, women didn't really talk very openly about their periods to people. So it's really only in the last couple of generations that we're starting to really get information about how common that may be. But we do know of a lot of people who have some genetic predisposition, it would seem, in their family. It doesn't seem to be a genetic disease that sits on one particular gene. It seems to be involved in a more complicated way. So it's not something that you can gene test for in the way that you can with single gene illnesses. Lymphatic or circulatory spread. This is something that somebody's suggested, where cells from the lining of the womb may get carried around either by the lymphatic system, through lymphatic fluid, or through blood into other parts of the body. That would explain why why occasionally cells have been found in incredibly far-flung parts of the body, and in fact, in places that it couldn't possibly have got to just by spreading. Immune dysfunction, this is a theory where it's thought that everybody may have some cells of it going on, but that the immune system of people who have endometriosis doesn't knock those cells out before they get started and embedded. So that's another kind of possibility. Environmental causes. Now, this is always a tricky one because we get a lot of people asking about this. There is no evidence in humans of environmental causes. There have been experiments done in animals which showed that a chemical called dioxin did induce endometriosis, an endometriosis type illness in animals, but as yet there is no evidence of whether that is something that affects human beings. So the jury is still out on that one to an extent. Metaplasia basically means sort of that they're cells that have mutated from their proper cause. And this would explain why it can be found in men, why it can be found in other parts of the body, because obviously if a particular type of cell can turn into another type of cell, then that would explain why it can happen spontaneously occasionally in men and in other parts of the body. So the truth is, it could be any one of these. It could be a combination of them, but until we get a bit more research done, we won't actually know what the story is there. So we're working on that at the moment. So getting diagnosed with endometriosis. The first line of this, getting diagnosed with endometriosis may take some time. That may be an understatement. As I said, 7.5 to 8 years is the current average time. Now, obviously, in the middle of a pandemic, this has become even more difficult because clearly things are very, very backed up and people are waiting a long time to be seen. But some of the symptoms of endometriosis are very similar to other conditions. So it can be, with medicine, a process of knocking things out before you discover what the actual cause is. The only definitive way to definitely say that you have endometriosis, people can suspect it, they can find it in other ways, but a laparoscopy, which is an operation where they put cameras into the pelvis, so it's like a keyhole surgery, they can look around and see endometriosis, and that's the only way that it can be 100% diagnosed. So you can be diagnosed as, 90, specialists can say, I'm 95% sure that's what you have, but until they've done a laparoscopy, they won't be 100% sure. Scans can be useful. The first thing that will often happen is that somebody will send you for an ultrasound scan. Sometimes endometriosis shows up on an ultrasound scan, sometimes it doesn't. If there are cysts, or if organs are very out of place or in a funny position or slightly misshapen, then that may help to diagnose. But we know for a fact that a lot of ultrasounds don't pick up endometriosis. The same is true, sadly, for MRIs. Some people have theirs picked up on MRI. I know somebody who's got very severe endometriosis and it never shows up on any of her MRI scans. So if you've been for ultrasounds and you've been for MRIs and they've told you don't have it, it's not necessarily the case. It just may be that it hasn't shown up in that particular way. Blood tests as well. Sometimes they want to do a blood test which is called a CA125, which is a test that they do for ovarian cancer. The trouble is that endometriosis can also raise that level. So that panics a lot of people because they get a high CA125 count and think, oh God, I have ovarian cancer, when they may not at all, because endometriosis can raise that. On the other hand, for some people, myself included, it doesn't raise it at all. So that's quite difficult. Some doctors can tell a fair bit through internal examinations, because if you're, for instance, if your uterus is tilted backwards or it's in an odd position, or your ovaries are in an odd position, it may give them cause to think that you may have it. So this is basically just to reiterate that. It says 7.5 years there, but I believe it's now gone up to 8 years. So because there are a lot of different symptoms and they can be quite unspecific and every woman is different, it's can take a very long time basically to be formally diagnosed. So when you gone forward one, so when you go and visit your GP, the thing to remember is that your GP is designed to deal with is trained to deal with thousands of conditions. They're diagnosing everything from sore throats through to cancer and everything else. So a lot of them are not particularly up to date with endometriosis. They're not particularly up to date with new research. We find that often they say, some GPs say very unhelpful things to people, like, why don't you try getting pregnant? That will make it go away. Spoiler alert, it won't. And they can often be quite unhelpful because they're not up to date with the most recent information. We always say to people, if you can, keep a pain and symptom diary so that when you bring it to the doctor, you have something to show them, to say, you know, here's what's happened over the last 5 months or whatever. This is my pattern of symptoms. It may also help you to kind of know when things are likely to be at their best or their worst. Please always bear in mind that your doctor may want to examine you and may want to do an internal examination. You don't have to consent to that if you feel uncomfortable about it, for many reasons. So obviously just be prepared when you go to the GP that may happen. If a GP wants to refer you to a specialist, it's worth finding out if you can go to a hospital that has specialists. Now, I can put a link in stuff we send out afterwards. We work with the British Society for Gynecological Endoscopy, which is a tongue twister if ever there was one, which is they have specialist centres that they accredit who do complicated endometriosis surgery. Some people who have advanced stage 3 or 4 endometriosis, or who have bowel or bladder involvement, automatically qualify under the NHS guidelines to be referred directly to one of those centres. They will often have not only specialist gynecologists, they'll have a bowel surgeon, a bladder surgeon, they'll usually have, they may also have pelvic physios, they may also have a pain management clinic, and they may have some psychosexual services as well, or women's therapists, that kind of stuff. So they're really worth, if you can, getting referred to one of those. And there are a lot of them, and they're all over the country. The problem is they have quite long waiting lists at the moment, so they are quite under pressure. If you get to see a specialist, people often struggle with what do I need to go in and ask. So this is just a list that Endometriosis UK put together of things that you might want to ask if you go in to see a specialist. And don't feel bad about asking questions. The trouble with NHS appointments in particular is you get a very short time to go through things. So, and I would say this for any health condition, write down and think about it in advance and write down questions that you want to ask, and feel free to write down their answers as well, because sometimes you come out of appointments and your brain gets kind of confused and you forget what's been said. So all of these questions are things that you could ask if they're important to you, particularly if there's things like fertility that you want to talk about depending on your age, or if you've had other surgery before, or there are other things about it. This last one is slightly frightening. Under what circumstances would you perform a laparotomy or remove organs? I just want to be clear that is not a usual thing. When we say referring to organs, that would usually be something like removing ovaries, but that should be agreed with people in advance. A laparotomy is where they go in to do a laparoscopy and discover that they can't do it by keyhole, and they have to do the old-fashioned way, which is a longer cut like a cesarean, and then do more advanced work. But all that should be talked about before you ever go for a laparoscopy. Some laparoscopies are just diagnostic, where they go in and have a look and then decide what they're going to do. But a lot of laparoscopies these days will also try and do some treatment while they're in there. That's an important thing. That's one of the important reasons why getting a specialist is really good, because they will often be able to find more and possibly treat some of it during the laparoscopy, rather than making you come back for a second surgery, having just done exploration. So NICE, which is the body that oversees the quality of care in the NHS, came up with some new endometriosis referral guidelines in 2017, I think it was. You can look, when I give you the link to Endometriosis UK, they have a link on there to the full NICE guidelines of how people should be treated and how they should be referred. But the quality statements that they put forward was that women presenting with suspected endometriosis have an abdominal and, if appropriate, a pelvic exam. That women are referred to a gynecology service if initial hormonal treatment with the pill or whatever is not effective, not tolerated, or they can't have it. And the third was that women with suspected or confirmed deep endometriosis involving the bowel, bladder or ureter are referred to a specialist endometriosis service, and that would be at the specialist centres that I was talking about. There are more complicated guidelines than that, and you can look them up, and everybody is able to look them up. And you can, if you've had trouble with your GP, you can print them out and take them with you and show them what they should be doing. I know that sounds terrible, but that's often what people have to do, is take it with them and say, it says here, we've done this, so the next step is to do this. And it always pays to be kind of forearmed. So endometriosis treatment, I'm only going to do this kind of quite briefly because there's an awful lot to this. Currently, there is no cure for endometriosis. Anyone who tells you there is a cure for endometriosis, a permanent cure, is lying to you and trying to sell you something. But there are lots of treatments that are available. Some of them may take away symptoms for women forever if they are lucky, and it may not reoccur for them. And some will need ongoing treatment of various kinds. We don't recommend anything in particular. We always say to people, you know, work with your specialist, your consultant, to try and work out what's the best thing for you, because it will depend on obviously your age, whether you're treating for symptoms of endometriosis in terms of pain and those symptoms, or whether you're treating for fertility purposes, because there's quite a different set of thoughts about what to do if you're considering getting pregnant or you're trying to get pregnant, from those who are doing it just for pain management. So the main three treatment options at the moment, and none of them are brilliant, I have to say, in terms of nobody particularly wants any of them, are surgery, hormone treatment and pain relief. Now surgery, as I say, is mainly by laparoscopy. Sometimes it's just to diagnose and to see what the situation is, so that they can plan a bigger surgery if it's more widespread, or sometimes it's to go in and actually remove some deposits. Now, when I had my surgery, all they did was take away the really big ovarian cysts that I had. I thought I was going to have a lot more surgery, but in actual fact, that was the thing that had been causing my really terrible symptoms. And so once that was taken away, that decreased it. So I would say to people, don't panic in advance if they say to you, you might need 3 surgeries, because you might not. After one of those surgeries, you might be considerably better. So it's best to kind of just see how things go as you go along. Hormone treatment. Now, there's lots of different hormone treatments, and I won't go into them in any depth here, but the main ones are the combined pill. Estrogen is factored into how endometriosis grows, so they do tend to put progesterone in. Some women can't work with a combined pill. Obviously, women over a certain age or with certain underlying health conditions are not advised to have it, in which case other options are progesterone only pill, which works for some people, but obviously can have some side effects. There are tablet versions of that. There's also the Depo-Provera injection, which some women have, which is an injected progestogen, which can manage symptoms for some. There's the Mirena coil, which is what I have, which is an intrauterine coil, which gives off over the period of between 3 and 5 years, a very low dose progesterone. And that is often, for some people, that's enough to stop periods. It can be enough to stop symptoms for the people it's lucky enough to work for. And as I say, because it only has to be changed every 3 to 5 years, it can be quite a long ongoing process. And because it's lower dose and more local, it doesn't give some of the side effects that the progesterone tablets do. As a more extreme, sometimes if people are having terrible symptoms, or if they're preparing for surgery, so they need to what they call downregulate the endometriosis, i.e. make it less active, they'll give you something called a GnRH analog, which people will know them as things like Prostat or Zoladex, which is basically a hormone blocker, and it will take all of your estrogen out, so that basically you go into a temporary menopause. And sometimes that can show whether your symptoms would be helped by surgery or whether there's something else at play there. Those are not recommended to be used in the long term because they can cause problems, primarily with osteoporosis. One of the things they can do now, though, is that they can give HRT add-backs with those to try and relieve some of the symptoms of going into very sudden menopause, which obviously nobody wants. So that can help by kind of making that a less severe option. In terms of painkillers, obviously you start off with the paracetamols and the ibuprofens. For a lot of people, that's not enough. So there are stronger not anti-inflammatories, things like naproxen, which some people use. There is obviously some women have to use codeine-based painkillers, which are either cocodamol, or sometimes at higher levels if people are post-surgery or have very severe pain. Some people have morphine. Obviously, that's not something you want to be doing for a really long period of time. So because you can get sort of immune to them, and obviously there is an addiction possibility there. So they try and keep that as low as possible. But there are now other drugs that can be used for pain, and some of these you can get through a pain clinic at the hospital, and some of them the GP can give, which are, some of them are antidepressants, but they're used at a specific dosage. So things like amitriptyline, or there's one called duloxetine, which are used at very low dosages, which can control certain pain symptoms. There's also specific nerve painkillers, which are things like pregabalin and gabapentin, which are can deal with people who have either pain memory from, because your brain can hold a memory of pain even when something's been operated on, or for people who have damage to nerves, or nerves which have endometriosis growing on them. There's the more simple things like heat. For a lot of people, heat packs are the absolute savior of the day, and there's a lot of discussion on our London group about which are the best heat packs. And so that, obviously in this weather, not a brilliant treatment, but they can really be quite helpful. Other things are, some people find TENS machines very helpful. So the same machines that people get for dealing with pain in labour, you can get one of those, and some people find those quite helpfully. But pelvic physio is one that we're really starting to try and recommend to people. Unfortunately, there are not that many specialist pelvic physios at the moment, but we're hoping that there will be more and more. But they can diagnose specifically, and they can give you exercises, and they can do work, some of it internal, some of it just things to do with hip flexors and stuff, to loosen up your pelvic floor, and therefore help often with some pain. And also that helps people often, in particularly in things to do with sex, or to do with bladder control or bowel control, or symptoms that they have in that area. So that's something that we really are starting to try and recommend to people. So that's the basics dashed through. I've just put up here our, to get the best link to resources, which are all in the one place, or if you're coming to this new, or you're just looking for more information, the website of Endometriosis UK is the best place to get anything. So I'll leave that up if people want to write that down. I'll also get it sent out. I think there's going to be an email sent out later in the week of some links. So I'll put it on there, because they have the links to basically everything, and to other groups and things that you can go to. And they have a whole load of stuff on there about more specific things to do with bile endometriosis, to do with sex and relationships, to do with all kinds of things that I obviously haven't had time to kind of go into specifically. So that's all from me. And as I say at the side there, any questions?
Thanks so much, Claire. That was really great, really informative.
No problem.
We do have one question to start off with. Can diet be used to manage symptoms?
It can be. The reason I have a slight hesitation is because everybody is different. There are people who will say that there is a specific endometriosis diet, and there are some dietitians who will do that. However, that, like a lot of conditions, that doesn't work for everybody. Some people find that diet has very little effect on it. Some people find that diet has a huge effect on their symptoms. There are a number of people who have problems, for instance, with carbohydrates or gluten type products. Some people find that a lot of the things that are triggering for irritable bowel are often triggering for endometriosis as well. So there are diets, there's a range of proof on whether they work. And as I say, they tend to be very individual. One that gets recommended for a lot of inflammatory illnesses in general is a thing called the low FODMAP diet, which is FODMAP. If you look it up, there's lots of resources on low FODMAP diets, which are basically trying to exclude foods that are known to have inflammatory properties. Unfortunately, it's a lot of the fun stuff, a lot of sugar, a lot of alcohol, a lot of those kind of things that tend to be sort of quite stimulating are also quite stimulating to inflammation. But yes, some people have had great success with it. I mean, I would say don't do anything extreme with your diet always, but it is worth it's worth maybe exploring certain things that you think might be giving you symptoms. It's why sometimes keeping a food diary alongside a diary of your symptoms can be very helpful on telling you whether there's particular things that you're eating or times that you're eating or what you're eating that is making a big difference to your symptoms. So the answer is yes, but not in a way that's entirely clear-cut or able to be recommended to everybody is the problem.
Thank you. Yeah, and we just got a message to say that someone else found that they had made some changes to their diet and had really great results. So
yeah, I mean, this is the thing. It's a very, we always say with everything with endometriosis, and this is the same with hormonal treatments or anything, it's a bit of a suck it and see approach. We get a lot of people who come along and say, has this worked for anybody else? But the truth is, we get that a lot about things like the Mirena coil or whatever. And the truth is, until you do it yourself, you just don't know, because everybody's body reacts so differently to things. So when we put up a post about the Mirena coil, we'll have 50% of people saying, oh God, it was the worst thing that ever happened to me. And the other 50% going, it gave me my life back. So it's very confusing to try and recommend anything for anybody because you just don't know. So I always say to people, you know, as long as it's not anything dangerous or that's going to leave you deficient in something, you know, try it out and see how it goes. Give it a little bit of time and see what happens. And do look online for the low FODMAP diets, because I know that has made a difference to quite a few people who suffer.
Yeah, we just got another message to say, wanted to say a huge thank you. This was very insightful and informative. This person was diagnosed with severe endometriosis in 2019 and has been navigating the journey since and has learned a few more things this evening. So that's really great.
Thank you very much. That's very kind of you to say, whoever you are. It's a scary thing to be diagnosed with it. And I think it's a scary thing to be diagnosed, particularly when you're told you have it severely, when you may not even have known you had it at all. And I mean, it's one of the reasons I got involved in this community is because A, it makes you mad when you find out how little we know about it. And B, because actually you can have those conversations with people who understand what you're going through and who understand the concerns that you have, and that's why I recommend always that Endometriosis UK runs online support groups. It also has a helpline that people can ring if they have specific questions, and obviously generally outside of the pandemic we run in-person ones as well. And we also have our Facebook, I mean our London Facebook group I think is somewhere between 1,500 and 2,000 people. So and there's 4 of us adminning it, so usually one of us is about, or one of the regulars who's there often will kind of have some advice, and we moderate all our posts, so we're quite careful about what goes up there. We don't give medical advice because we're not doctors and we're not qualified to do so, but we do in our in-person support groups. We try and bring we quite often have one of our endometriosis specialist nurses there. Endometriosis in the specialist centres has a specialist nurse in the same way that oncology or some of the other departments have, which means that they can sometimes answer questions the consultants are too busy to get onto. So when it comes to things about hormonal treatments or about pelvic physio or whatever, sometimes they're an easier person to talk to. So we try and bring them to our in-person meetings where possible in London, so that they can give a bit of medical advice, because we step back at that point and say, no, that's not something obviously that we're equipped to do. But yeah, it can be a long, lonely road. And so I think all of us who have it are trying to band together and make a bit of a movement. And you'll have noticed that in the last couple of years, there's been an awful lot more talk about it in newspapers, in magazines, on television. The presenter of BBC Woman's Hour, Emma Barnett, is now an endometriosis sufferer and has been quite open about it and talked about it. Endometriosis UK did a whole photo campaign with Rankin, the photographer, who took some pictures of very high profile women as well as regular women who have endometriosis. So there is a real push on finding out more and getting more people involved. So, you know, it doesn't have to be a lonely road. There are lots of us out there battling together. So do get involved if you feel it's something you kind of want to be involved in, because you'll be very welcome.
Okay. What age is typical for starting to investigate internally, so laparoscopy? Is there a certain age where that would be recommended?
I don't think there is a certain age. There used to be a talk about, I mean, obviously nobody wants to operate on the under 18s where they don't have to. I mean, often I think in teenage years, they will often try hormonal treatments like the combined pill and stuff first. One of the nice guidelines is that ideally they should try some form of hormonal treatment for 6 months. And if it's not helping, then look at referring people on to a gynecologist. Because quite often, if the symptoms are controlled by hormonal treatment, and if the person is not necessarily looking to get pregnant or not suffering really heavily with other symptoms, then quite often hormonal treatment is at the moment the kind of first go-to option. So unless people are suffering with symptoms that are not controlled by hormonal treatment initially, I think probably most doctors would say they wouldn't necessarily want to go in and do laparoscopies to diagnose too early. Just to say, there are people who have endometriosis who have never been diagnosed by laparoscopy, but they have it controlled by other means. So I think it's very much determined on what your symptoms are. I mean, the reason I had a laparoscopy was because one of my cysts had got to 12 centimeters, which is basically like carrying one orange and half an orange I was carrying around, and the level of pain was so terrible. So sometimes there are points where a laparoscopy is unavoidable because it really needs to be done to do some treatment. And that's particularly if it's on nerves or if it's, you know, attaching things, then there will be. But I would say that's something that a surgeon would make a decision based on what the symptoms were and what had already been tried before they would kind of dash to surgery. They're not overly keen to dash to surgery at all, partly because the waiting lists are very long, and partly because obviously every surgery, no matter how small, has some risk factors. So obviously they try not to do it unless they really think it's going to bring something useful to the diagnosis or to the treatment.
Thank you. Can you recommend support groups for teens?
Oh, now that's a tricky one. There is actually a section on the Endometriosis UK website for, there's a section about advice for teenagers. So I would say probably go and look at that. I'm not sure whether there are specific groups for teenagers. I have to say that any teenager is always very welcome to come to any of our support groups. As to be honest, you know, we sometimes have support groups where, you know, people can bring their parents and family members as well. And sometimes if a teenager wants to attend, you know, with a parent, then obviously that's something that can be done. I don't know of any specific ones. I'm sure the web being the web, there are probably communities out there who are talking to each other in the darkest recesses of Tumblr, or, you know, various other bits of the internet where people go to congregate. I don't know of any specific ones, but I know that there is a section on the Endometriosis UK website about teens. So I would say go and have a look at that. And they may have some more suggestions on what would be appropriate. I also know we Endometriosis UK tries to do information days as often as they can at various hospitals in London. We used to do them quite regularly before the pandemic. We're hoping we're going to be able to get back to them because we've done them at the Royal Free. They did them at Homerton out in East London, and we've had a number of teenagers who have come to attend those sometimes with their parents, which has been really helpful because it's helped their parents understand as well as them. and that helps to kind of support them in their journey to what comes next. So yeah.
Thank you. And then the last question is it's sort of around the issue of being diagnosed and not feeling like you are being treated well in that diagnosis. You know, how do people with endometriosis deal with this, and how can we go about making this better for people who are going to be diagnosed in the future?
It's very difficult, and let me tell you, if you've had a bad experience with doctors, you are not in the minority. In fact, I'd say you're probably in the majority. The horrifying things that some doctors have said to people I know beggars belief, and some of it is down to ignorance, and some of it is down to just not really knowing what the protocol should be. The Endometriosis UK has been working with the Royal College of Gynecologists, and it's also been working with GPs to try and promote a bit more education on endometriosis diagnosis, and obviously with it being a bit more in the press, we are trying to get out there. The problem with GPs is obviously they're constantly getting new advice on how to diagnose all of the 4 million things that they can end up with. So it's always a slightly tricky kind of one to get through. Definitely, I think that if people are in a, they will tend to get more knowledgeable treatment at a specialist centre. The thing we've said, this is my secret top tip, the thing we've said to a lot of people is, if your doctor refuses to refer you on to a gynecologist and says, oh no, they don't want to do that, ask them to document in your notes that they are refusing to do it. And you'll be amazed how quickly, when they have to document their refusal of something, they may well change their mind. No doctor likes to be quoted in writing as having refused to do something. So a few little slight guilt trips like that can actually work. But you're absolutely right. It has not been acceptable at all. And I think Endometriosis UK is campaigning. It's done quite a lot of work with MPs in Parliament recently, both about getting the menstrual wellbeing on the curriculum and also working with GPs and professional organisations to ensure that it is better taught to medical students, that it's better taught to doctors, that it's more widely recognised, and also that the research budgets for it are kind of increasing, and that they're looking at more important, the important factors behind it, and also at getting proper treatments, because we have some brilliant endometriosis specialists in this country, really, really expert people. But the truth is they are slightly working in the dark, because until we know what the causes of it are and we know what other treatment options are out there, they're having to work with what they have, which is not ideal for anybody. And at the moment, obviously, they're having to work in quite straitened circumstances. So it is difficult. And I think one of the things is that's one of the reasons why we're kind of all banding together to try and, sign petitions, do sponsored walks. We have an endometriosis, there's a worldwide endo march every March, which we've had to cancel 2 years in a row now, which is really annoying, where we usually go on a little march through the centre of London. They do it all around the world, but we do it in central London, and we go around handing out flyers to bemused people who get these weird flyers on painful sex and things that they probably didn't want on a Saturday afternoon. But we're sort of absolutely determined to kind of keep that going and to keep it in the public eye, so that doctors and politicians and policymakers cannot ignore what we're trying to do. And we hope that things will start to improve shortly. But yes, bad experiences with being diagnosed are not uncommon, sadly. Brilliant. Thank you very much, everybody, for coming. I hope it's been helpful. Been a whistle-stop tour, but I hope it's been helpful.